Okay. Hello, everyone, and welcome to today's GRMG webinar with Dr. Elvira Grandone. For those of you new to the GRMG is a global initiative that aims to connect students, researchers, and early career professionals to experts all over the world. And today we are delighted to be hosting Dr. Elvira Grandone. Dr. Elvira, please take it away.
Good morning, everyone, and thank you for being there. I know it's early for you. It's good to me. And first of all, I would like to thank you all and your enthusiastic group and Professor Ma Ottman for involving me in this very interesting to me initiative. And now I will try to share my screen. Can you see?
Yes.
Yes. Okay. As you know, today we will talk about assisted reproductive techniques and link with thromboembolism. We will talk about risks, mechanisms in terms of physiopathology, and a little bit on clinical management. And first of all, these techniques are used for infertility issues. And if infertility is defined, as you can see in this slide, as a failure to conceive after regular unprotected sexual intercourse for 2 or more years in the absence of known reproductive pathology. And this is an issue for many couples worldwide, and in US it has been estimated that from 15 to 13% couples have this type of issues. And in that case, we have to use these techniques. The most known of them is IVF, that is the acronym for in vitro fertilization. So the agenda today is about thromboembolic risk with some details on epidemiology, incidence, and clinical relevance. After this, we will talk about mechanisms and the risk factors, focusing on individual risk factors or technique related risk factors. And lastly, we will talk about prevention and clinical management with a focus on the present guidelines. The incidence of venous thromboembolism, defined as the occurrence of venous thrombosis with or without pulmonary embolism in relation to assisted reproductive techniques in general, or to IVF, that as I said is the most common technique, has been reported about 0.1% to 0.5% of all cycles, meaning that the incidence, overall incidence is low. But we know that in some cases we can have not only VTE, but arterial thrombosis too. Today we will focus on VTE because it's in general more frequent than arterial thrombosis, and well, a little bit well known compared to arterial thrombosis. We know, for instance, that arterial thrombosis occurs often about 10 days is early after the embryo transfer, meaning that is occurs earlier than venous thromboembolic events. Whereas, as you can see here, we know from observational data that venous thromboembolic events occur later, 42 days after the embryo transfer, and the risk, however, can last, we will see this later, can last throughout the entire pregnancy. However, the absolute incidence and absolute risk of events is higher when some additional factors, as I said, individual risk factors or factors related to the heart procedure occur. For instance, and the most known is the ovarian hyperstimulation syndrome, in which the thromboembolic risk can last from several days to weeks after, more or less 3 months after the syndrome is resolved. During the assisted reproductive techniques, we have some modification regarding the coagulation activity. For instance, we have an increase of fibrinogen von Willebrand factors, factor 8, and factor 5. And this is more or less what we can see during contraception with estrogen and progestin pills. But this is seen also during pregnancy. So this increased procoagulant activity characterized use of hormones, and in particular hormones and gonadotropins that we use to stimulate ovary to produce more follicles and so on. When patient has, I would like to use the word woman. These are not patients really; they are women. So when a woman has or shows specific risk factors, for instance, thrombophilic risk factors, especially in a family with venous thromboembolic events, especially in young people, or with in women with obesity or with smoking habits or other comorbidities, and especially in women with an advanced age, obviously we can have an increased risk factor, risk of VT compared to the background risk. Usually due to the increased procoagulant activities and to the reduction of endogenous anticoagulants, especially protein S levels, we can see very often in women undergoing this treatment an acquired protein C resistance. Again, this characterizes also pregnancy and characterizes also use of pill. Furthermore, we have a sort of inefficacious fibrinolysis, and so the increased risk is due to treatment that we use, especially, as I said, treatment with gonadotropins, and personal risk factors as those listed in the slide. But the very interesting, at least from my standpoint, the very interesting aspect is that many risk factors for VTE associated to pregnancy are the same risk factors for VTE in women with infertility issues. And more in detail, I would like to highlight the role of, you can see here the acronym that means polycystic ovary syndrome. And polycystic ovary syndrome is a relevant issue for women suffering from infertility. And we are going to see in a few minutes some relevant aspects from a physiopathological point of view. Polycystic ovary syndrome is associated with thrombotic risk in general, and more in detail with venous thromboembolism. As you can see, the syndrome, polycystic ovary syndrome, affects between 8 and 13% of women with reproductive potential. So it's a huge amount of women in reproductive age suffer from this syndrome that is characterized by signs and symptoms of hyperandrogenism, oligoanovulation, and at ultrasound polycystic ovarian morphology. These are the most recent international criteria for diagnosis of the syndrome, and in presence of 2 out 3 criteria, we can diagnose this syndrome. Now, a vast majority of patients with polycystic ovary syndrome show chronic insulin resistance, and this is independent on the body mass index, because we see in our words, we see many women with higher body mass index, but in some instances we have women with low body mass index. They have the same chronic insulin resistance as women with higher body mass index. And here you can see that we have a low-grade subacute inflammation that characterizes these women, and the inflammation coupled to insulin resistance and hyperinsulinemia is responsible for an increased risk for vascular function. And this means that these women have, as I said, a higher risk of thrombosis in general, and in particular of venous thromboembolic events. On the other hand, these women, women with the polycystic ovary syndrome, have a higher risk to develop during the ovulation induction. They have a higher risk to develop the ovarian hyperstimulation syndrome. And this means that when these women with COS develop the OHSS, the risk dramatically increases. This is my personal image from women. These are ovaries, not yet an ovarian hyperstimulation syndrome, but this is just a so-called normal picture of a control ovarian stimulation. But you can see here, these are follicles, and the ovaries are very large compared to an ovary during a physiological cycle. And as anticipated, the ovarian hyperstimulation syndrome, especially the severe forms of the syndrome, can be associated to a controlled ovarian stimulation in 1 per 1,000 until 2% cycles, and the moderate syndrome can be found in 3 to 7% women undergoing an controlled ovarian stimulation. But what is the pathogenesis and physiopathological steps of the ovarian hyperstimulation syndrome? As you can see here, we have, first of all, a release of vasoactive factors that determine a capillary leakage in the third space, so-called third space, meaning outside vessels, with tissue edema that can lead to ascites, hydrothorax, and in the most severe forms of the syndrome, to a compartment syndrome. On the other hand, you have a hypovolemia with an hemoconcentration and that can in turn determine an hypercoagulability that can lead, as you can imagine, to thromboembolic events. But we have many type of different protocols with different pharmacological approaches to induce the ovarian stimulation. And we know from our practice and from case reports that only some drugs, first of all, as I said, gonadotropins, but also human chorionic gonadotropins especially, are associated in our patients to an increased VTE risk. This very elegant paper recently published has shown that when women take these pharmacological drugs with human chorionic gonadotropin, they show an increased thrombin generation. You can see in this case and in this other case different protocols, but both both protocols are characterized by the use of HCG. In this picture, you can see what happens in terms of thrombin generation. No change in thrombin generation when you don't use this prothrombotic agent, when you use different protocols. So this means, we are trying to teach to our colleagues of fertility centers that some protocols can be more easily used for women at higher risk of VTE. So not all drugs are associated to thrombotic risk, depending maybe basically from a different thrombin potential. Looking back at the ovarian hyperstimulation syndrome, as you can see here, women older than 40, women with comorbidities have a higher risk compared to younger women or to women without lots of comorbidities, have a higher risk, as I said, to develop a VTE. And we can see, and not only VTE in these women, but as you can imagine from the physiopathology of the disease, we can have, for instance, acute renal failure, acute respiratory distress syndrome, and so on, that can lead to life-threatening complications for these women. However, we have to take to bear in mind that in the risk of VT, this is recently reported in a review with meta-analysis by a French group, the risk of VTE when the ovarian hyperstimulation syndrome occurs is high, very high, is about 15 times higher compared to women without ovarian hyperstimulation syndrome, although the confidence interval, as you can see here, crosses the unit. But please bear in mind that, as I said, these data are from observational studies, are from small sample case series, and this is the reason why the confidence interval crosses the unit. What about other risk factors? We do not have a clear idea of about the magnitude of the risk for each single risk factor. For instance, the magnitude of the risk for body mass index, for some specific comorbidities, or for instance, thrombophilia, especially the severe and mild thrombophilias, and most common, I would say, thrombophilias such as factor V Leiden or prothrombin mutation. So most of the information that we use in our clinical practice derive from studies about pregnancy, and so we have a very indirect evidence. And as I anticipated, we distinguish, as you know, mild and severe thrombophilia. We should test women approaching ART for thrombophilia only if a personal history or a family history of VT is present. As recommended by the World Health Organization, we should not test all women undergoing ART or undergoing prescription of contraceptives, but we know, at least this is true in Europe, not sure in US, but maybe it's the same, all women nowadays, all women undergoing ART are studied for inherited and acquired thrombophilia before starting a cycle. And this data obtained in women with reproductive potential included in the Riete registry show that we are very scared about complication, thromboembolic complication in these women, in that most of our patients with a VTE issue during an ART cycle show an isolated pulmonary embolism, I would say, or if you like, isolated pulmonary thrombosis compared to women with VT during contraception or women who develop VT during the postpartum period. And this is maybe the reason why our fertility centers are particularly worried about the VT risk in women, for instance, approaching for the first time a cycle. In addition, we know that in general and independently of the development of the ovarian hyperstimulation syndrome, but in general, population approaching IVF, the risk of VT during the following pregnancy, when I say when the attempt is successful, the risk during pregnancy starts at the very beginning of the pregnancy and lasts until the end, compared to you can see here the red line compared to natural conception pregnancies. In Italy, we have obtained in a small group of women in our region, in the Puglia region, we obtained exactly the same results as I showed in the previous slide, with an incidence of about 8 per 1,000 women who develop VTE in pregnancies after an ART conception, compared to about 2 per 1,000 events in women who conceived via a natural conception. And again, these are results, findings obtained from the meta-analysis I have just mentioned. This is reported here, and you have in the meta-analysis about 3 times higher risk of VT in general, so independently of the presence of other risk factors. So in general, pregnancies following an ART conception compared to natural conception. Overall, we have that, as you can see, a polycystic ovary syndrome shows a relative risk of about 5 times higher of VTE. And again, when we have a successful IVF or ART cycle, meaning a cycle leading to pregnancy, we have about 14 times higher risk compared to unsuccessful ART attempt. And again, so we should pay attention not only to the period of stimulation, but also to pregnancy when the ART cycle is successful, for the reason I am showing you. The risk maybe lasts until the end of pregnancy. We do not have exact data, robust data regarding, as I said, the different settings of women with different risk factors, but overall we know that successful cycles and in general IVF cycles when followed by pregnancy need more attention by our clinicians. And now the last points regarding prevention of the risk and clinical management based on the available guidelines, international guidelines. Some words, few words about aspirin. Aspirin is not helpful. It's not helpful not only because it's not helpful to prevent venous thromboembolic risk, but even for fetal prognosis in terms of live births. This meta-analysis, systematic review and meta-analysis clearly showed that aspirin is not helpful. We have in addition Cochrane data with exactly the same results. What about US? And for this reason, aspirin is, as you can see here, is contraindicated by all guidelines so far available in literature. On the other hand, low molecular weight heparin is suggested or recommended to avoid, as I said, to avoid VTE due to or associated to the ovarian hyperstimulation syndrome. As you can see, we have these are Royal College guidelines, and these are SCCP from US guidelines. But we have so many gray, so-called gray area, because as I anticipated, we do not have much information about the weight of each single risk factors for our setting, different settings of patients. So what should we do, for instance, in presence of 2 or 3 risk factors included mild thrombophilia, or included some comorbidities, or included age? Again, we usually decided according to studies and information available for pregnant women. So we have again indirect evidence, but this is at best of our knowledge, this is what we can suggest, not recommend, but we can suggest today. We recommend, as I said, low molecular weight thromboprophylaxis only for ovarian hyperstimulation syndrome, as I say. And now let's move to conclusions and take-home messages. I would like to conclude that, as I have tried to show you, the venous thromboembolic risk is not common, but has important clinical implications. And we should focus, especially as far as VT is concerned, on ovarian hyperstimulation syndrome after the ovulation induction, and on polycystic ovary syndrome that is often diagnosed and often leads to the infertility treatment. Furthermore, when we finally obtain a pregnancy after an ART cycle, independently of the ovarian hyperstimulation syndrome or other risk factors, we should take in mind that the risk of VT is, however, a little bit higher, significantly higher than that derived from natural conception. And the individual risk assessment should be suggested not only before initiating the cycle, but also during the entire pregnancy following the cycle. And these are my take-home messages. We always should consider the risk of venous thromboembolism when approaching an ART cycle. I would say, must use heparin when the ovarian hyperstimulation syndrome occurs. Thrombophilia testing should be reserved just to women with personal family history or with a higher risk of venous thromboembolic events. And last but not least, multidisciplinary collaboration between reproductive medicine specialists and thrombosis experts are absolutely necessary, mandatory for a safe ART management. Thank you for your attention.
Thank you, Dr. Grandone, for the amazing presentation. Very, very interesting and important topic. And now we're going to open the floor to any questions. Does anyone have any questions? Please raise your hand. Yes, Pierre.
Yes, thank you so much for your presentation. It was very interesting, and I didn't know much about this topic before, so it was very interesting for me to learn. And I just wanted to ask you, because since you mentioned that successful ART could lead to an increased risk of VT compared to spontaneous pregnancies, would this be kind of because of an additive risk, because of the risks of VT because of infertility and the added risk of VT during pregnancy? Or is there kind of some specific mechanism as to why this risk is higher, if that makes sense?
Thank you for this very interesting question regarding pathophysiology, basically. But unfortunately, we do not have specific data about mechanisms. And so the best things, okay, the ideal study that I can imagine should be to follow women from art cycles with a successful, I would say, art cycle, and follow them throughout the entire pregnancy and compare them to those with natural pregnancies. For instance, it should be very interesting to measure thrombin potential. Or maybe we should also test throughout pregnancy. Okay, it is desirable not to start pregnancy when the ovarian hyperstimulation syndrome occurs, but sometimes the syndrome occurs after pregnancy positive test, meaning that we cannot stop the pregnancy. And then in these cases, I think it should be more interesting to follow, for instance, with thrombin generation tests or measuring other markers, prothrombotic markers, in order to have a comparison between women with pregnancies after ART, without ovarian hyperstimulation syndrome, those with hyperstimulation syndrome, yes, I guess that they have a higher thrombin potential, and the control group could be women with natural pregnancies. I think could be interesting, and this is the reason why I showed you the paper published in Fertility and Sterility regarding thrombin generation. It's very interesting, but I think that we are at the very beginning of the story.
Thank you.
Dr. Osman just pasted a question to the chat. She said, what future research studies are needed to support polycystic ovary syndrome?
Are needed to support, sorry?
Polycystic ovary syndrome.
Oh, yes, who have, as I said, just observational data and no randomized control trial. Sometimes we do not have prospective studies, because I think that in this case we should design good prospective studies. It's difficult to randomize. This is my perception. For many reasons, it's difficult to randomize these women. It's very, at least this is, as I said, my experience. But we should use registries, prospective registries, and for instance, to follow women with polycystic ovary syndrome versus without, and in some cases maybe we will use heparin depending on individual risk, and try to stratify at the end of the registry, hopefully with thousands of women. I think that the effort should be international collaborative study, but at least in my mind, we should design prospective studies. This is my experience. Not possible to recruit for a randomized control trial in this setting.
Mhm. Also, following that, I had a question. So you mentioned that insulin resistance develops with some polycystic ovary syndrome patients. Is there any data concerning which subpopulation has the highest incidence of developing insulin resistance?
Again, it's very interesting, mechanistic steps. Maybe I'm wrong, but to my knowledge, to the best of my knowledge, no. As I tried to explain, we have different phenotypes of COS with low body mass index and high body mass index. Insulin resistance is common to both, but maybe not sure. Not sure, and as I said, not so. Maybe I'm wrong. I don't know all literature, all the available literature, but maybe there are some differences about lean versus overweight and obese women, although all have insulin resistance.
Okay. And also, I had another question. So, for the increase in risk compared to IVF versus natural pregnancies, which populations receiving IVF or fertility treatments have the highest risk? You mentioned a few characteristics. So, how do those rank, if you will?
Again, it's an interesting question. You know, I am leading in Italy national guidelines about this. So I have in the last 2 years I was obliged to study everything about this topic, and it is very frustrating because yes, we tried. We have, you know, we are using the grade methodology because our Italian Ministry of Health ask us to use this rigorous method, but so we have a methodologist on board. She's an hematologist and I am the so-called expert, but again it's frustrating because we do not know exactly how to weigh age, weight, class of weights, class of BMI, and so on. And this is very well, if you have time, please read the meta-analysis by French group I have cited, because they have a very interesting graphical abstract with so many question marks regarding exactly what you are asking. Yes,
Okay,
thanks.
thank you.
Thanks.
I see we have a question from Maria. Go ahead.
Hello, everyone. Dear Professor Grandone, thank you very much for the great presentation. And I apologize for being 5 minutes late. It's just my computer decided to restart. I would like to ask a question. Well, first of all, I'm quite new to the field, and my major is in biophysics, biomedicine. Therefore, I am really interested in diagnostic tools that are applied for the personalized thrombosis risk assessment prior to the ART technologies being used. So, yeah, could you please kindly clarify this?
You mean about diagnostic tools in this specific topic?
No. What I meant is like prior to the interventions, right? Like in the individual health, one should really consider like the state of health and should assess it with all the type of diagnostic tools that are, I don't know, feasible in the clinics. And so what type of the diagnostic tools are you using? Like, let's say the woman comes and she says like, yes, I would like to have the IVF. And so you start, I would assume, with blood tests, right? And other type of tests. So are there any, I don't know, novel types of technologies being involved or?
Okay. Yes, yes, thank you. Thank you for the question. It's a very interesting question. Most of the times, patients come to me with a thrombophilia screening already performed, prescribed by their fertility clinics. But as you know, in our, at least in Europe, but in our general population, more or less 15% people, including women approaching art, have some mild types of thrombophilia. And this is for us a big issue because, for instance, we have in Italy 3 to 4% of factor V Leiden or prothrombin heterozygotes. But presently, my attitude is to try to stratify the risk not only in terms of diagnostic coagulation tools, but also from clinical standpoint. For instance, first of all, the age, the body mass index. In addition, I try to have additional information from fertility clinics regarding type of drugs that they want to use, type of cycle, short versus long, and what happened in the past. For instance, when women, if they use the pills, what type of pills, because pills as well as for instance a previous pregnancy can tell me as a clinician a little bit more than diagnostic tools, at least presently. My hope is that, I am confident that global tests in the future can help us. But we do not have, with the exception of what I showed regarding thrombin generation test, to the best of my knowledge, we do not have other diagnostic tools that can suggest who is at higher risk. Do you have some suggestion that can be helpful for me, or would you like to, for instance, study some patients of mine?
Well, actually, I would like to, reflect a bit and brainstorm upon the presentation because I was really, really impressed. And maybe I could write you later an email and to propose several things if you like so. I would be honored.
I am honored too, and it will be a pleasure to have something to share with you. Yes, thanks.
Thank you.
Yes, Vera, go ahead.
Yeah, sorry. So I had another question. I don't know if this is extremely kind of in the scope of the presentation, but I was just wondering, because endometriosis is also quite a common cause of infertility, as far as I know. Is there any studies or information about how endometriosis increases the risk for VT as well? I was just wondering.
Yeah, yes. Again, an interesting question. Yes, it's, as you said, outside of the scope of our presentation today, but it's an interesting question because endometriosis, again, is associated with a low-grade inflammation. And in this sense, especially in the most severe forms of endometriosis. So we have women with very severe forms of endometriosis. Yes, this is associated with EVT risk, as most of the inflammatory disease, for instance, diabetes and so on. But again, if I am correct, we do not have studies, specific studies, especially endometriosis is quite common, has become very common nowadays compared to when I graduated many years ago. I don't know if this is due to a better capacity of us to diagnose. I don't know exactly, but the reality, our reality is that we have many endometriosis today, not again at different stages. So yes, I think that the risk should be a little bit more explored, but the risk, yes, definitely we have the risk of VT.
Thank you.
I also had another question. This may be more basic, but a lot of us are still a bit new to the field. So I believe you mentioned that the WHO does not recommend thrombophilia screening to everyone. Is this more of a cost case, or is there risk with thrombophilia screening?
They simply say it's not cost effective. But to be honest, there is another type of literature, not exactly medical literature, but sociological literature. It's very interesting because it was completely unknown to me. And this type of literature suggests to study, especially women, because women, first of all, can have the opportunity or can have the choice to take the pill. And we know that the risk of different classes of pills, the risk is different according to type of combination or type, because for instance, a progestogen only pill is not associated with an increased risk. So this is, a reproductive choice. So so contraception is the first step of the woman life. After this, we have pregnancy, and again, to be informed about possible generic risk can be, for instance, this does not mean that we in the case of factor V Leiden without any history, personal or family history, yes, we do not prescribe at all drugs, but we can stress a little bit more lifestyle and so on before getting pregnant. So you can perform just once during the life, the screening for pill, for contraception, for pregnancy, for hormone replacement therapy after menopause, again, and for art. Okay, so some authors, as I said, suggest that should be cost effective for women, especially for women during reproductive life, and also some American guidelines of genetics, if I correctly remember, they suggest, again, just for women, and for these reasons, they suggest to perform once in the life, at least the inherited the thrombophilia screen for inherited thrombophilia.
Thank you so much.
Thank you.
And I believe if there aren't any further questions, we can end the webinar. Okay.
Thank you.
Yeah.
Thank you so much for coming and for presenting to us. It was very interesting to learn about this.
Thank you. Thank you so much.
Thank you so much.
Thank you.
Thank you, Dr. Grandone.
Thank you. And with great pleasure, if you want to write me again or to have some additional proposals of study or